Dr. Srinivasan from Vellore, Melvisharam, Apollo Hospital. Today I am going to talk about systemic hypertension. First, I want to give you small brief introduction about systemic hypertension. Hypertension is one of the leading causes of the global burden of disease. It affects more than 1 billion and around 9.4 million deaths per year. By definition, it is a measurement of the force exerted by blood as it pulsates through the arteries. So, what are the causes for our hypertension? Usually, primary hypertension, secondary hypertension, two types are there. Primary hypertension, mostly 80 to 95% due to genetic and environmental factors. Secondary hypertension, that is 5 to 20%, that is due to various causes like renal disease and cardiac or adrenal, renovascular, aortic, obstructive sleep apnea, and neurogenic causes. Many causes are there. So I want to discuss briefly about few factors as well as few causes, and then finally our topic proper update in hypertension. So environmental factors for our primary hypertension, most common etiology is obesity and weight gain, and then high sodium intake and lower potassium and calcium intake, then stress due to our fast culture and due to our lifestyle, varying lifestyle, and excessive intake of alcohol and sedentary lifestyle. These are all the environmental factors contributing to our hypertension. And genetic factors, it estimated around 30 to 40%. So, renovascular causes, arteriosclerosis, fibromuscular dysplasia, renal parenchymal disease, and renal polycystic kidney disease, as well as renal tumors, some obstructions or vascular causes. In adrenal, primary aldosteronism, Cushing syndrome, pheochromocytoma, then coarctation of aorta, obstructive sleep apnea, then neurogenic cause, psychogenic, then decompensated diseases, familial dysautonomia, polyneuropathies, and acute intracranial rise of pressure, then acute spinal cord dissection, and endocrine causes like hypothyroidism, hyperthyroidism, then acromegaly, then very important cause like drug-induced high dose intake of steroids, nasal decongestants, appetite suppressant, then tricyclic antidepressant, monoamine oxidase inhibitors, erythropoietin, NSAIDs. What are the various manifestations? Most important CNS manifestations like cerebrovascular accident, multiple lacunar infarcts may happen, cognitive impairment may happen. In cardiovascular disease, we all know coronary artery disease like unstable angina, NSTEMI, and ST elevated MI maybe occurs. In renal, acute kidney injury, end-stage renal disease, then peripheral arterial disease, very important, thromboangiitis obliterans, then in eye, retinopathy, retinal hemorrhages, then vitreal hemorrhage, sometimes extraocular palsies also will happen. Coming to the very, very important classification of hypertension, current guidelines, ESH, European Society of Hypertension, it designed in 2018. So optimal BP should be less than 120 of systolic, less than 80 of diastolic. Normal 120 to 129 of systolic, 80 to 84, and in grade 1 hypertension 140 to 159 of systolic, 90 to 99 of diastolic, grade 2 160 to 179. Isolated systolic hypertension greater than 140, diastolic may be less than 90. So coming to the very another important guidelines like American Cardiological Committee referred these guidelines. Elevated BP when 120 to 129 of systolic, less than 80 of diastolic. Stage 1 of hypertension, that is 130 to 139. Very important point here. We have to remember this point. 130 to 139 of systolic, diastolic 80 to 89, and stage 2 of hypertension, that is greater than 140 of systolic, greater than 90 of diastolic. So in measurement of BP, we cannot rely on single measurement. So office BP also, we can use it for screening purpose only. Home measurement or continuous blood pressure monitoring is confirmatory one. So whenever high risk is there, that is like cardiovascular disease, then associated diabetes, chronic kidney disease, then we have to take further lesser level of BP levels should be taken as serious. Then our target should be in 80 to 65 years age group, less than 140/90, greater than 65, you can take little bit higher, that is 150 by 90 you can take. Coming to the latest updates, as per WHO guidelines, 63% of total deaths due to non-communicable diseases attributable by our cardiovascular diseases 27%. Out of this 27%, 45% of people in 40 to 69 years of age, it is due to lack of awareness about hypertension, lack of appropriate care, and poor follow-up. In India, prevalence in male around 38%, in female around 32%. It happens in last 30 years. Despite this various measurement and various awareness scheme, but still around 62% of male still drug withdrawal is there. Around 52% of female drug withdrawal is there. Then, as per International Society of Hypertension guidelines, optimal care refers to evidence-based standard of care, and same time, essential care means specification of essential tools of care for low resource cities. That is very important. So, coming to the recent guidelines, another guideline, that is in ARDS like picture, metoprolol also useful in reduce the lung inflammation that is caused by COVID-19 induced ARDS. So metoprolol also plays a role in reducing the inflammation. Then lowering systolic BP targets down to 110 to 130 in STEP trial as well as sprint study trial. These two trials plays very important role in hypertension management. Then coming to the 2000, based upon our 2018 European guidelines, it recommends not only dependent of office BP measurement, also out of office BP measurement. That is, home BP monitoring is very important. It is 24 hours monitoring over the period in daytime and night time also. Even in night time, very important. For every 20 by 10 increments of BP at night, it increases the risk of cardiovascular risk over the 23% in the patients. So in night time, if someone systolic BP over 20 increment and diastolic 10 rises, so it leads to high cardiovascular risk. You have to very careful about these steps. So most of hypertension patient requires lifestyle modification. As we discussed, up to stage 1 with no risk, we can give only lifestyle modification, that is non-pharmacological treatment. We can observe over the period of 3 to 6 months. So we have to repeat BP as well as, and we have to look for end organ damage over the period of 3 to 6 months. If step 1 with high risk patients, we have to start on anti-hypertensive. That is A, C, D. Like A means ACE inhibitors, C, calcium channel blockers, then diuretics. Current guidelines recommends that dual to start antihypertensive with the dual fixed combination of ACE inhibitor or ARB. These two together are calcium channel blocker with diuretics. Then another recent guidelines, that is ARBs like valsartan. These produce a known carcinogen like NDMA, that is nitrosodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan. In all type of sartans, it produces NDMA. It leads to with so many cancers in over the period of 4 years of intake. So we should avoid this valsartan and some type of sartans with high dose. Then very important IGR study, largest study, it tested nighttime antihypertensive treatment. It tested when nighttime therapy, it exerts a favorable cardiovascular risk reduction. So the IGR study proves that nighttime treatment of antihypertensives, so we can reduce the cardiovascular risk. Very important studies. Then 24 hours home BP monitoring. Nowadays, we are monitoring in one or two sittings in at clinical basis, that we should not do. Definitely, we have to do two more seated BP readings in more than two OP visits. Already we said 18 to 65 years of age group, up to 140 by 90, we can wait without risk factors. But with risk factors, we have to take it as serious when BP of one greater than 135 bar 85. So how to manage this patient? Weight reduction is most important. Then DASH diet, that is high protein, high fat, and low carb diet. Then decrease the sodium diet. Physical, increase the physical activity. That is 30 to 40 minutes per day, weekly 5 days of minimum. So, initial drug of choice, as we discussed, ACE inhibitors, ARBs, thiazide diuretics, calcium channel blockers. Ideally, we can give dual drugs. Then we have to keep few side effects of drugs. ACE inhibitors are strictly contraindicated in pregnancy and those who are planning for pregnancy. ARB is also contraindicated. Beta blockers again contraindicated in athletes and AV black patients. Diuretics are contraindicated in gout, pregnancy, and metabolic syndrome. So, how to proceed with uncomplicated hypertension? Initial therapy, we are going to start with ACE inhibitor along with ARB or another combination like say, calcium channel blocker along with diuretic. So, if patient BP is not controlled, we have to proceed with to step 2, that is triple drug combination. So ACE inhibitor, ARB along with calcium channel blocker along with diuretic. So we can try these three. So we can assess the patient after 2 to 3 weeks. If still BP is not controlled, we have to go for triple drugs. With this, we have to add aldactone 25 to 50 mg once a day, or other diuretics or alpha blockers like prazosin or some beta blockers we can add. So beta blockers indications, especially in heart failure, post-myocardial infarction, atrial fibrillation, young females planning for pregnancy, we can prefer beta blockers. So, what is complete coming to the completion purpose? What is hypertension urgency? So, the BP more than 180 by 120 without tertiary organ damage, without terminal organ damage is hypertensive urgency. Here, we have no need to correct rapidly. In case of hypertensive emergency, BP more than 180 by 120 with end organ damage. So here, due to avoiding end organ damage, we have to correct rapidly. That is by we can give IV idalicin or IV Lasix or some nicardipine, labetalol. So many drugs are there. We can give based upon the clinical parameters. We can give the drugs. What is malignant hypertension? That is sudden onset of hypertension in previously normotensive individuals. In hypertensive encephalopathy, we are preferring nitroprusside, IV labetalol, and nicardia. In malignant hypertension, labetalol, nicardia, nifedipine, or enalapril. In myocardial infarction, we are preferring nitroglycerin and labetalol, esmolol. In PAH, idalicin, labetalol, nifedipine. In aortic dissection, if we suspect aortic dissection, then nitroprusside, esmolol, labetalol, we can give. Coming to the final conclusion, what we are going to take home point is ideally we should monitor that is home BP monitoring is must. Then nowadays it not only happens in elderly age group, it nowadays due to the our lifestyle changes, it happens in young age also. So we have to be very careful, and it causes so many complications, CNS and respiratory system and renal system and peripheral arteries. So it affects almost entire organs in the body. So we have to be very careful. So then lifestyle modification is very, very important. Then recent guidelines suggest that dual drugs combination is ideal for to start any to overcome the hypertension. So thanks for giving this opportunity. Thank you.